So Dr. Chappell, talk to me a little bit about ultrasound as an imaging modality, as an option for patients, and why maybe ultrasound has some advantages over like X-ray and MRI and some disadvantages.
I guess I've spent way too much time behind an ultrasound because I use it for most stuff. Some disadvantage to ultrasound is bone. We can see the cortex of the bone, so that's the outer part of the bone, but we can't see through the bone. Can't see the other side of the bone. So there are some limitations when it comes to like deep structures like an ACL in a knee, a PCL in a knee, or a labrum in a hip, or a labrum in a shoulder. Because a lot of it's surrounded by bone and we can't see it that well. So those would be some limitations. So those structures obviously seen best with X-ray or MRI. Some benefits, one of my favorite benefits of ultrasound is that we're not limited by views. So we don't have to have a standard view. There are standardizations of what we can do if we're presenting to our colleagues, but if somebody can't move like for instance in a certain position, they can't put their shoulder in a certain position, so we can't get the X-ray that we want, we can move the ultrasound to get the ultrasound that we want or the image that we want. And it also allows for dynamic testing, meaning for X-ray, you hold super still, or MRI for that matter, and you take the picture. And if your pathology or your problem it only shows up in a certain position, then we don't get that position. With ultrasound, we can put the probe on and then ask you to perform the thing that hurts and go through a range of motion to see if we can see the problem that is causing. So dynamic testing is super fun and super useful with ultrasound. But the deeper structures and through bone, we can't usually use for diagnosis. So if you think you have a fracture, go get a different test.
Yeah, for sure. And yeah, on X-ray, our dynamic testing is just like weight bearing. And so we get a little bit of like stress or whatever dynamic testing there, and MRI, you're just laying perfectly still. So yeah, sometimes being able to see the motion of the structure through kind of an entire range of that joint's capabilities helps you isolate things that you wouldn't otherwise see. What are some of the things on ultrasound or what are some of the ways that ultrasound can help you treat like pathologies in the shoulder, say?
So I guess we'll go back to X-ray, called fluoroscopy. So you can use fluoroscopy to guide a needle to a site, but there's exposure to radiation during that time. It's pretty precise, and you need a couple different views, but the provider and the patient gets exposed to radiation during that time. With ultrasound, however, so in the usefulness of treatment, we can use, once again, sound or real-time imaging to direct our treatment. So in this case, if we're putting an instrument or a needle and we want to be in a very specific location to identify a very specific pain generator, we can see the location, we can see the needle, we can see the medication or the activation of the tool, whatever we're using, flow through that area. So so it's very precise as far as precision, hitting the actual targeted tissue that we want. And it's like I relate it to, because the technology is really the same as a fish finder. Right? So I'm going fishing, it's on the back of my boat, I'm looking at my screen, and I see echoes down at the bottom. And I know those are fish because I've looked at them for a long time, like, oh, that's what a fish looks like on a fish finder. And so if your fish finder is really good, you can stick your bait in the water, and as soon as your bait starts going down, you'll see your bait moving down towards the fish. The problem with I guess the beginning of ultrasound, just like X-ray, if you have one view, we'll quote you, one view is no views, we'll think that our bait is right next to the fish. And then we're like, oh, that's awesome. I'm right. Why is the fish not eating my food? It's like right on top of it. But what you got to realize, you have to flip it another 90 degrees or 180 degrees and look at the other view, and you realize, oh, they're not overlapping. They're actually showing up on the same screen, but they're not in the same location. And then you can adjust that way. But those views also allow us precision. I mean, so we look at one view, there it is. We look at the other view, there it is. We're right in the middle of it.
You mentioned in your presentation, you mentioned PRP. Do you mind kind of explaining a little bit about what PRP is?
I would love to.
And why that's kind of a direction that, in sports medicine and orthopedics and non-operative sports medicine, we're kind of moving towards a biological solution as opposed to necessarily always a surgical solution for a problem.
So PRP is useful in a lot of things, right? And I think that's where ultrasound comes in. It's also not useful in a lot of things, and surgery is required. That's why I love like ultrasound, because we can stage it and we can give a real expectation to a human. Like, my shoulder's not getting better after all these conservative things. Well, have you had an image? Like, no. Well, let's image it. Well, guess what? It's not going to get better until you get your rotator cuff repaired. So how's that relate to PRP? PRP stands for platelet-rich plasma. So it's just a blood draw. Take your blood, spin it down, blood separates into layers. Plasma on top, red blood cells on the bottom, and in the middle, there's something called a buffy coat. It's just a layer of platelets and white blood cells. We actually want that layer. That's the platelet layer. So you've asked a question that really gets me excited or angry, one of the two. So if I take a tube of blood, say I just drew your blood today, and I set it right here on this counter for an hour, and come back and look at your blood, it will be separated into components. You have plasma on top, red blood cells, and platelets and white blood cells in the other component. So if I took any component of that material, it would not be platelet-rich plasma. It would be some platelets in some other material. And so we centrifuge it to separate in those layers, and we specifically want that layer. The rich part of the platelet-rich plasma means it's been concentrated to a certain amount, typically more than 2 times its existing concentration, but hopefully around 4 times existing concentration. So people heard the term PRP a ton and never understood that's what it meant. And so you also mentioned it may work, it may not work. And that's true. All of our studies show that. It works sometimes and it doesn't work other times. What the studies don't show is the concentration of the platelets, typically. So there's some better studies coming out that do. And they don't show the concentration, and they don't show the processing methods. So processing is extremely important, and the timing of processing is extremely important. The longer you let blood sit around, the less platelets you're going to have, because they want to stick together. And so processing that is very important. Then we take that material and we have to put it back in a very, very specific site. So historically, say 10, 15 years ago, maybe even more recent, 5 years ago, a lot of studies came out that showed, let's say lateral, so golfer's elbow or tennis elbow, for instance. PRP worked for it. And the next study, PRP didn't work for it. And in neither of those studies was actually guided. So they put PRP where it hurts, but platelets where they aren't, like in healthy material, don't do anything. I mean, you have platelets circulating in you all the time. They're not like doing everything. So they're not magic. You actually have to put them in the area of problem, I guess the problematic area. And guidance is the best way to do that. And when you're dealing with soft tissues, so PRP has been shown helpful in a lot of like soft tissue injuries, tendinosis, tendinitis, ligament problems, plantar fasciitis, things like that. And our terminology is getting better to describe those things, but it works well at stimulating an inflammatory response, because in a lot of those overuse injuries, your pain is not eliciting inflammation. It just is pain. Pain doesn't make healing occur. And so we have to, or we get to, or we choose to, whatever, I have to use a strong word, we can put platelets into that area, and the platelets start an inflammatory cascade, which then can promote healing. So now your pain and your healing are in the same room versus just having pain.
Mm-hmm. Yeah, absolutely. There's, some of the kind of classic indications for PRP are, lateral epicondylitis, tennis elbow, proximal hamstring, gluteal tendon, rotator cuff tendon. And I think it's the targeted, the concentration level matters. And then I think also coupling it with some sort of physical therapy or activation, because we're trying, at its heart, degenerative tendons are a biology problem. And so in my mind, it makes a little bit more sense to attack a biology problem with a biological solution. What are some of the pathologies from a patient perspective? What are some of the pathologies that you've seen the best results with PRP for?
I think you mentioned a few. So anything to do with a tendon, an insertional tendon problem, or where the muscle turns to tendon and then inserts on bone. It's where it goes from tendon to bone. That's the hardest to heal, and most chronically overused areas. So we call it tennis elbow or golfer's elbow or jumper's knee, Achilles tendonitis, plantar fasciitis. And they're all pretty much insertional problems where it goes from tendon or fascia or ligament to bone. And it works really well on those. And like the setting of like golfer's elbow, it probably should be the treatment of choice. And unfortunately, insurance doesn't cover it. And so people are paying for it, but it doesn't mean it doesn't work in this case. So.
Yeah. From a patient perspective, talk about the cost of PRP.
So cost ranges depending on the provider that you use. So it's anywhere, I would say, between $300 and $2,000, depending on who you're using. And that would cover the guidance, the ultrasound, the processing, and the injection of the platelets. The other thing I think it's important to know, if you ever go somebody and say, hey, we do one PRP injection and you'll be better, you should probably not be there. Because we don't know that information. In my practice, it's about 2.2 to 2.4 would be our average number of PRPs for, say, a lateral epicondyle or a golfer's elbow or a tennis elbow, or even ulnar collateral ligament sprain. And so it's going to be between 2 and 3 in my office, and maybe more. That means it doesn't mean we can't do 4, because if you're like 80% better after 2, we can do more. We're not going to overdose you on it. So that's the good part about it. But it also may not get to perfect either. But yeah, as far as cost, I don't know if that's expensive or not. I guess it depends how much money people are willing to spend on their elbow.
Yeah, it's all relative.
Yeah.
Stem cells in Mexico sometimes are $20,000, and people fly there to get those. So I don't know. All right. Hey, thanks so much.
You're welcome. Thank you.